morning, everyone, and welcome to the session, A Recipe for Multicenter Collaborative Telehealth Research. We're excited to have you all here. My name is Jenna Cope. I'm a Senior Public Health Analyst at HRSA in the Office for Advancement of Telehealth, and I'll be moderating today's session. We have two fantastic presenters and a great presentation today. I'll go ahead in just a minute and do very brief introductions of our presenters, but we are hoping to keep this as a fairly interactive session. There will be some polling and some Q&A discussions toward the end. The polling will be throughout today. So please keep an eye out on that. We'd really love your thoughts and questions as well as we go through the presentations. So please feel free to use the Zoom box to the right and embed it in the screen. So the presenters and myself will also be keeping an eye out for those questions so we can make sure to get to those today. And again, keep an eye out for the topics and discussion points. We'd love to hear your thoughts on those. And we will go ahead now and just introduce our presenters. We have Dr. John Cho is the Neonatal Improvement Officer for the CHOP Newborn Care Network, co-director of the Digital Health Innovation Core at the Children's Hospital of Philadelphia, and Associate Professor of Clinical Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. And we have Dr. David McSwain. He is the Chief Medical Information Officer at MUSC Health in Charleston, South Carolina, the main principal investigator for the NIH-funded SPROUT-CTSA National Telehealth Research Collaborative, and the chair of the section of telehealth care at the American Academy of Pediatrics. So I will transition over to our presenters and we will take it from there.
Thanks, Jenna. John, thank you.
All right. I think Sean was going to share the slides, but I can go ahead and do that if that's okay. Let's see. Okay. Let me just go ahead and share my screen quick. All right. And we're off. So one of the things that we want to do today is really kind of give you an idea of what a collaborative research enterprise may look like and how to begin to even kind of visualize what that means. But before we do that, we wanted to kind of touch a little bit on what we mean by when we say investigate telehealth. Dave will be able to tell you a little bit more about our center grant, a UO1 grant from the NCATS later on, that was designed to exactly do that, to help support telehealth research. But we can think about it as telehealth impacting the doing of research, right? So, and how telehealth impacts the patient care. So in the first case, it's really how we can support our principal investigators who are doing clinical research or doing other kinds of research unrelated to telehealth, but we can use digital technology to help them be more efficient and more effective in doing research. The second one is really using telehealth as sort of the intervention of how we can improve patient care, improve the delivery of healthcare, and at the very with the very goal of improving health outcomes altogether. There are three kinds of, I like to think of three kinds of investigation in telehealth. The first one that I think we're all very familiar with if we're doing research is really the trials, right? The research trials. And when you're doing telehealth, how it impacts the doing of research, or the impact of patient care, I like to kind of bring you to the PICO question format, in which you can ask something to the extent of, in X cohort of research studies, for example, where you're using telehealth to help doing the research, does intervention Y, so if it's teleconsenting, that could be the intervention itself. Does intervention Y compared to in-person consent, for example, impact the recruitment rate? And so that's one way to sort of ask that research trial question if we're looking at that. But if we're looking at how telehealth impacts patient care, you can ask in X cohorts of patient, does intervention Y, let's suppose it's teleconsultation in our example, compared to in-person visits, impact an outcome Z. So for example, maybe it's the obesity rate, or maybe it's access to care, or maybe it's the, reduction in costs or unnecessary health utilization, that kind of thing, right? So that would be sort of a research where you have a control group and you have a comparison group and the intervention group, and you have an outcome outline, and you have the cohort population identified. More and more now, we're seeing telehealth being used as in quality science. And this is when you're trying to apply to the IRB and looking to be exempted, one of the ways to do that is to show the IRB that this is indeed a QI project. So in doing research, you can ask the question, basically the same intervention, but you can ask it a different way. You can ask it, can telehealth consent improve recruitment rate from 50% to 60%, let's say, within 6 months? So that's what we call a smart aim in our QI world. And that would be quality science. And if it's to impact patient health or patient care, you can ask the question of what can telehealth consultation reduce the time to subspecialty consultation from 60% or by 50% within 6 months. And then the third type of telehealth investigation is really a really important one, and I think it doesn't get as much credit as it really ought to be sometimes, and that's a descriptive. So you're really describing landscapes here. So the question there that you can ask is, how is telehealth being used in the conduct of research? How is what's the prevalence or incidence of using teleconsenting, for example, versus inpatient consent? So you're really kind of describing what's actually happening. And you can ask the same for how telehealth impacts patient care. And the descriptive studies are usually the kind of studies we start out with, because we're trying to describe what our current state is. And then oftentimes in the descriptive study, you point out gaps. And these gaps become targets of research trials and quality science later on. And when we say, by the way, when we say telehealth, we are saying telehealth as a larger umbrella that includes telemedicine. So for example, your video visits, your video consultations, your e-consults as well. So the asynchronous and synchronous. But telehealth also includes mHealth. It also includes tele-research. It also includes teleeducation. And one of the broader applications of using this kind of technology. So that's our sort of level set on when we say investigate telehealth. This is sort of the gamut of things that we could possibly mean. And as you're thinking about this, we hope that come up with some questions of how in your world what kind of things that you'd like to see done with telehealth research. Okay, I'm gonna hand it over now to the poll question. So we're gonna ask a couple of polls now that we've kind of had this intro, and you're gonna have two poll questions. The first is going to indicate what kind of research study you'd like to be most comfortable with. And the second one is what kind of research study do you want to see more of? So I'm gonna hand this over.
We're gonna hand over control back to Sean so that we have our audience participation. There we go.
Great. So what type of research study would you be most comfortable with? So this is really this is interesting. So we've got 6 respondents so far, and right now descriptive studies and research control trials seems to be top of the list, and followed by quality improvement. And now descriptive studies. We'll give it a few more minutes for the audience to answer
that. Sean, I think if you're still standing by, we have a few folks who are looking for the poll. I believe it's back in the portal.
That would be correct.
Okay, thank you for the confirmation for folks who are looking for it.
Back in the portal on the right-hand side, right, Sean? On the right-hand side of the screen?
It should be, yes.
Maybe we'll give it maybe a few more seconds.
Just one more repeat back for those, if any are still looking for the poll. If you go back to your Mobi portal where the session is listed, you'll see it on the right-hand side of the session. You'll be able to answer it.
I think what we're seeing here, Dave, if I'm reading this trend correctly, is that it really does reflect some of the conversations we've had with SPROUT and others of what kind of study people are actually really more comfortable doing or think that is more sort of appropriate for telehealth.
Yeah. Well, I think that gets a lot of it gets the timeline. We're going to have a little bit more discussion of this in a session tomorrow as well. But, you know, one of the big, what do they call it, pushbacks or barriers to conducting research in telehealth is that it does tend to evolve quickly. And certainly for traditional research methodology, folks generally think of that as being slower, more protocolized, more difficult to kind of take that agile approach. I think quality improvement processes are much more capable of going through that rapid cycle type approach. And one of the things that we're learning now, and we've had some great presentations in some of our SPROUT ECHO programs, and Jen Rosenthal from UC Davis talked last month about some of the more rapid cycle research approaches that could be applied effectively to telehealth. So, but the fact that folks are more comfortable with quality improvement probably gets more to the approach that a lot of folks working in telehealth really have to take in order to keep up with this more rapid evolution. And I think, you know, descriptive studies, the thing that's interesting to me, that occurs to me as we're thinking through this, and then we'll talk in more detail tomorrow, is when you look at what people do with data and analytics as a driver of operations, you know, getting actionable data, delivering it on dashboards, allowing your business leaders, your operational leaders, your clinical leaders to respond to that data to help drive business and operational decisions. That's really descriptive studies, right? It's much the same approach. It's showing you what's happening in your operations now, what's happening in your program now, and allowing folks to essentially react to that to make business decisions and operational decisions. So I think folks are probably more familiar with descriptive studies than they may even realize, as since a lot of it is similar to just the data and analytics visualization.
Yeah, I totally agree with you, Dave. The other point I think that you know I've realized over the last couple of years is that each of these types of research or telehealth investigative approaches is not mutually exclusive. What we've done and seen a lot of is, you would use descriptive data to really kind of give you your landscape so that you could identify your problem for your QI project. And then even within the QI projects, when you're trying to figure out, which interventions you want to do first, because you're trying to prioritize, sometimes you go back to the evidence and you go back to trials that's been done before to try to help inform you of which interventions is most likely to succeed.
Yeah,
and
that's an approach we very intentionally took with the SPROUT landscape study. When we were originally starting up SPROUT, obviously you're very familiar with this for the audience. What we realized is that there was not a high level of awareness of what people were doing around the country in pediatric telehealth, and that was a huge early barrier to actually developing collaborations, pulling people together, and getting the process of developing a research study started. Because if you don't know where you're starting from, you don't know how to, where you're going. And so the first, big study that we did was that just an assessment of the current state of telehealth, of pediatric telehealth across the country, and publishing that landscape data saying, this number of people are doing neonatology programs, and that's what they look like. This number of people are doing PICU programs or school-based telehealth, and also describing kind of how those programs are set up a little bit, what the funding is like, what the administrative support looks like, just to establish that baseline. So that was really, I think, a descriptive study. And then we've built on that from there. And one of the things that you see a lot in telehealth is quality improvement initiatives that kind of transition into research as you see impacts that are happening. And that's a good way to have a springboard into research in a little bit more of a rapid cycle fashion.
Great. Now we have the second question. The second polling question is, please indicate what type of study do you want to see more of? And this is really interesting, Dave. I think, well, most people are very comfortable doing quality improvement. What they really want to see more of is the research trials, right?
Yeah. And that's, I think, something, we're not the only ones. I mean, you look at policymakers and payers, and really the big discussion around the country now, as we're moving beyond the pandemic, is what do you do with the temporary reimbursement policies that were put in place, and how do you drive those decisions? And the way to drive those decisions, and the Office of Management and Budget and the Congressional Budget Office and Medicare and Medicaid, they're all asking for data, and that data needs to be unbiased, rigorously obtained, and directed towards the questions that they want to see answered. And that means that it needs to be research data. It can't be market data. It can't be, just retrospectively collected data on utilization. They have that, for the most part. They have feasibility information and can do this. The question is, what's the best way? And in order to really get those answers, we need the research approach.
Great. And I see some chats are still starting to form, so that's great. We'll definitely be able to take each of your questions as we move forward with this. We will have the majority of this is going to be actually a Q&A. So great. So hang on to your questions. That's the one caveat, I think, Dave, is and which is why this, we kind of put together this talk, is that when you want research data, you need lots of data, and you need enough data so that you can do some of the control into stratifications of your cohorts. And this is why I think multi-center collaborations are really key to this. And so that we can kind of pool our data together. Now, to do that, we kind of follow in the footsteps of multi-center clinical research that's been done, where there is some standardizations that needs to be done in terms of data definitions, collecting the same reliable data, not only the same data, but with very clear definitions, and doing it reliably out in the different heterogeneous pool of institutions that may be collaborating, and so it takes a village, in other words. And so what I'd like to do is like to present in maybe the next 10 minutes to a way to visualize what a collaborative research enterprise or effort would look like, and what are some of the processes that is required. Some of those we've been building quite a bit within the SPROUT grant itself, and we'll talk a little bit about that as well. So I'm going to go ahead and thank you for taking those polls. We have one more after this towards the end that we love your participation with, and it's a little bit fun, so we'll save that for later. But I'm going to share my screen again and continue the presentation.
And while you're pulling that up, John, I see there's a comment in the Q&A from Alyssa Terry. I am in two groups trying to write subspecialty practice guidelines for telehealth, and research trials are lacking in our specialty. And the reason I call that out is because it actually really helps intro SPROUT a little bit, because that exact problem is one of the reasons that SPROUT was formed. And I was in a subspecialty writing group for the ATA's pediatric practice guidelines back in kind of 2014. And we encountered that exact problem when we were looking to develop evidence-based practice guidelines. There was no evidence. And so that was one of the kind of foundational challenges that we were looking to overcome when we established SPROUT, to try to help folks in generating the evidence to develop best practices.
Great. So I love to start with this, and I love this quote because from Martin Luther King: if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep on moving forward. And this is I think I feel like we're preaching to the choir here, and many of us in our respective institution is really having to keep moving forward. And I think one of the side effects of the pandemic has been really kind of a boost in terms of making the case that digital health technologies, telehealth, i.e., has a place in clinical care and has a place in research. And so with that, what I like to do is ask the question: so what does an organization that supports collaborative research look like? And I'd like to kind of introduce, or maybe not introduce, maybe you've heard of this already, this concept of going from an organizational chart to an organizational view of a system. So Richard Buckminster Fuller have said, you never change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete. I think Steve Jobs at Apple have really done that and have kind of lived up to that thought. So what we like to do is on the left-hand side, this is your typical organizational chart. Okay, so this could be an organizational chart for a collaborative research project, right? A multi-center project where you have the sort of the PI and you've got some of the sub-awardees and etc. And those who are responsible for different things. What I like to do is take us from that view of an organization to the one on the right, which is very process focused. And I'll show you how we make something like that, and then I'll show you how this connects. This is really important concept because without this view, it's very difficult sometimes to put our arms around sort of the beast, the monster, right, of collaborative telecare. And this would be one way for us to be able to do that. So when we look at an organization view of a system, such as a collaborative research activities, what we've done, and this is kind of what we've done with our SPROUT, is we start on the left-hand side of what the existing or current state is. And on the right-hand side in that green box is where we want to go. So we now have multi-centers doing research, but all in silos, right? But what we like to end up with is collaborative multi-center research, because we want to accelerate improvements of outcomes in this way. And that outcome could be health outcomes, that outcome could be your research productivity, it could be other things, right? In between is how we get from point A to point B. And what I've done is here, I've listed maybe 6 of those high-level things, but I'm sure those on the call can probably think of a few others. But we start very high level. So one of them is really identifying opportunities for learning and studies, right? This is where the descriptive studies come into place, right? Where we kind of see what's going on, right? We need a forum to facilitate networking and collaboration. We need a way for institutions and teams to communicate with each other, right? And we need to create telehealth tools and frameworks. I think before the pandemic, many of our telehealth platforms even were sort of, companies were struggling actually, and there was only a few big players for telehealth tools, but now there's more. But not only the platform is important, but also the tools by which we measure telehealth, right? The tools by which we want to evaluate telehealth, and we can talk a little bit about the STEM framework later on. But there are other tools, right? There are tools to evaluate cost effectiveness, tools to help inform policy, right? So some of these tools are not available and are beginning to be developed very quickly. And then we want ways to support and facilitate and support studies, right? And then when we support these studies, whether having the expertise to do this, to design studies is really important. Our partnership with CTSA was a big move to that. Thanks to Dave and your efforts. And through the grant, we're now able to match the CTSAs with Sprout and then combine. And Dave, you talk a little bit about that later on as well in some of our questions. And then finally, we a place to disseminate best practice and disseminate and go to conferences and really kind of share our work and then get input from the community of what they like to see, and I think this collaboration with our community is so important. But by itself, this without support processes, without understanding what drives and influences some of this, we really can't do anything, right? And this is great. This is a great diagram or a way to look at this. But without the support processes, we really don't get anywhere. So what I like to do is just really quickly then just show you these are some of the support processes on the bottom, and on the top, it shows you some of the things that are important in determining, how successful we can be. So I'll start on the bottom because I really like the processes. So we have 5 categories here. There's something in the system of collaborative telehealth research that manages collaborative groups, right? So for example, in Sprout, we support topic working groups. We have meetings, we have webinars, we have conferences. All of those things, okay, will influence how successful we are. Just managing operations, this is things that we all don't really like to do, but it's sort of, you have to do it. So what are the policies, procedures? If we are lucky enough to have grant funding or foundational funding, how do we manage our budgets? How do we support technology? And we want to be as agnostic as possible in communicating, but we need to support something and some technology. And really, when I say technology, it's really technology to facilitate collaboration, not necessarily technologies to do telehealth, but to support collaboration. Want to manage information because we learn a lot, we gain a lot of information with our colleagues. Well, can we organize that into libraries, share folders, listservs, and how do we liaison with other organizations such as the AAP and medical societies, right? So all of these are sort of processes to help us, succeed. And you could even imagine within each of these boxes, you can dive deeper into sub-processes, but we're not going to do that. But we could do that if we really are really trying to, dive into the details. But on top is really important too. So there is some process that determines national, state, and local priorities, right? And so we better know that, right, in order to do that, because those priorities is what determine regulatory policies and legislation in telehealth. And then there are practice standards. I think, Allison, you had mentioned before, practice standards that you're trying to come up with, not, for clinical practice, but there's also practice standards for telehealth that have emerged. And then, I think, Dave, you've worked really hard on a practice and procedures for telehealth that was endorsed by the AAP. So taking some of that as well, and then determining something out there is determining funding policies and how, these projects can be funded. So we all had better know that. Once you have a map like this, okay, you now begin to understand what are the processes that go in and the things that go into success for multi-center collaboration research. You could do the same exact map for a program, all right, to do that. And when you do this, and notice what I've done here is all of the different boxes start with a verb, because these are processes, these are actions. And what then you can do is you can start to overlay people and tools that are responsible for doing these. Each of these. What's kind of neat about seeing this world like this, and by the way, I want to give full credit to Cliff Norman. He's one of my mentors in quality improvement that I met at the Institute of Healthcare Improvement when we took the Improvement Advisor course, and he introduced me to this concept of looking at an organizational view instead of an organizational chart. Because what happens is, once you have this, you can now begin to see the interrelationships of these processes. We start with managing collaborative groups, and when we do that, we facilitate networking and collaboration. And when we do that, we can begin to create telehealth tools such as STEM, such as policy, such as econ and QI frameworks. Then we can use those tools to facilitate and support studies and then disseminate them, create learning hubs. And then we then go back, and with some of these learning hubs and information is then managed back in the support processes, which goes back to the collaborative group to facilitate more work and more collaboration and more tools and more studies. So with a map like this, you now begin to understand all the interrelationships between telehealth. And I think if you're looking for a recipe, this is a version of the recipe. And I think what you can do in your own institution, in your own microcosm, cosm of collaborators, is to kind of think of it this way, which would, I think, begin to help you determine what your system would look like. So I'm going to stop right there. Because what we like to do then is I think Dave's going to talk a little bit about the SPROUT-CTSA network and an example of using something like these concepts of systems, Dave.
Yeah, and I love this graphic that you provided, John. I think because when you look at research, a lot of the ways that people focus on research and program development as well is in that middle section. But I think when you're really talking about developing a collaborative network that's moving the needle at a large scale for the healthcare system, for the practice of telehealth, for the practice of healthcare, it has to involve both that top section and the bottom section, which is where I think a focus on those areas is just as important to what we've been able to build with Sprout as that middle section. And oftentimes those things get overlooked. I think you look at, the top section, looking at policies and kind of those national, state, and local drivers. You need to understand that as you're developing your research initiatives, because it gets to not only your ability to drive collaboration because of a shared understanding of the need, but it also gets to the impact of the research that you're doing. You want to develop research that's gonna actually have an impact on the way people practice and the way the industry is evolving. And I think that's one of the ways that the approach with Sprout has been successful. That bottom area around managing your collaborative groups, managing operations, documenting the knowledge, doing all those things, that's the nitty-gritty details of how you make something sustainable, of how you make it functional, of how you really establish a meaningful network, that's more than just a collaboration of folks that have similar interests. And that's another area where, and as you mentioned, some of that stuff isn't our favorite activities. But that's why we have really good support folks as well that have been really helping us with that aspect. So, Sprout, and there's a lot of different aspects of what the SPROUT-CTSA network does. But really, the biggest focus is around education and collaboration. And John mentioned the topic working groups. That's kind of our core foundational subunit, so to speak, because there's so much variability, there's so much variation, so many different types of telehealth that people are doing, not only in the pediatric space, but beyond, that the first thing you need to get your hands around is that definition of what you mean by telehealth and what type of telehealth people are focused on. And so the topic working groups is our way of focusing in on particular aspects of telehealth, particular program types, and really allowing those collaborations to develop. And one of the things that we've also been very careful about is having kind of a federated leadership model for the TWIGs. Our goal here is not for me and you and our executive leaders of Sprout to have control of telehealth research across the country. Our goal is to empower other people across the country to do productive research to move their efforts forward. And we do that through this federated leadership approach, where we identify people that are interested in particular areas of telehealth and doing research in those areas. And then we identify folks around the country who are interested in leading those twigs. And identifying a empowered, passionate leader of a specific area, of a specific twig, is probably the most important aspect of moving those twig efforts forward effectively. And we've got some really great twig leaders who have stepped forward and just done a great deal of work to move some of these initiatives. So now, of course, everybody's familiar with what happened with the pandemic and the way that COVID-19 just shoved telehealth right into the forefront of the healthcare system. And we were very active kind of early on in that process. And one of the reasons we were active and successfully active is because of the way that we had built the whole program. We were able to convene folks rapidly, pull together experts from around the country, and give them a forum and an audience to share what they were doing and learn from each other in terms of best practices and overcoming challenges, and really responding in a nimble way to the pandemic. So we had the first national COVID-19 telehealth webinar on March 12th, which, if folks recall, was very early on, kind of during, I think it was like the first week of the nationwide shutdown. And we had the first national webinar on integrating support for non-English speaking populations on May 13th, because in the process of convening these groups, we realized that this was a shared challenge in terms of the support for non-English speaking populations. And we were able to pull folks together to talk about that very early on. Now, certainly, if folks are aware of any earlier efforts, let me know, because I don't want to be saying that it was the first national example of these things, that it wasn't. But we really, as far as I'm aware, we were the first group to pull together a real national group of experts to discuss in a conference/webinar format how to address these challenges. So, and then, thanks to a lot of work by John and many others, our STEM framework has been leveraged extensively and really built upon to support research efforts and to really guide those research efforts in response to the pandemic. We developed a COVID-19 specific STEM framework that provides metrics and measurement approaches for programs that were built or expanded upon to address the pandemic. We also have developed the SPROUT STEM policy, our policy STEM framework, that is not really so much exclusively devoted to policy questions, but it helps to frame research questions in a way that folks that work in the policy space can understand. And meaning it breaks it out by the different stakeholders. You look at different metrics and measurement. And sorry, my dog has decided to enter the room. Hang on just a sec. So, sorry about that. It allows you to break out the metrics and measurement approaches by what's meaningful to different stakeholders. So looking at, are you talking about patients? Are you talking about providers? Are you talking about hospital systems, policymakers, or payers? The things that are important to those different stakeholders may differ, especially in a fee-for-service type environment. Something that makes money for the hospital system is going to cost money to the insurer. And there are a lot of different examples of that. So the STEM policy framework tries to put a little bit of structure around that sort of approach. Our economic evaluation framework is certainly addressing one of the primary concerns and questions around the expansion of telehealth, which is, is this cost effective? How do you build this in a way that will be economically viable for a healthcare system, for a payer? And we are in the process of, that's actually pending publication. And there's a question there, is the policy STEM framework publicly available? We've done a couple of presentations showing that. We're working on getting that published as we speak. So hopefully it'll be publicly available soon. And then we're working on an integrated care STEM framework, working closely with folks from Boston Children's and others on how to address medically complex patients and coordination of care. We've also expanded our TWIGs pretty significantly. The two that really have a lot of interest as a result of the pandemic is the equity and disparities TWIG, which we started up several months ago, but has, I think, over 90 participants and is really doing a lot of great work. And we've also developed a telehealth education TWIG and that's really around not educating about telehealth as, in terms of defining it and giving presentations about different programs, that kind of thing. So much as how do you train your staff? How do you train your residents? How do you train the folks that are actually going to be conducting telehealth visits? How do you, and that can be a multi-professional team, how do you support the education of your team to conduct telehealth? And that obviously became a huge issue during especially the early phases of the pandemic, when people, and I'm sure there are many on this call who are familiar with this challenge, when you suddenly went from training, maybe 1 to 10 or so people a month on telehealth programs to suddenly training hundreds. And that is something that folks had to scale very rapidly. And then finally, Sprout supports people across the country in grant applications and grant funded initiatives. So again, we're not looking to be the gatekeepers of telehealth research. We're looking to empower folks to not only conduct research, but to get funding for their research. And so we've provided letters of support. We've provided consultation on metrics and measurement. We've done a lot of things to support folks in getting grant funding. One of the most notable ones is the AAP's CARES funding from HRSA and Maternal and Child Health Bureau to support pediatric telehealth. And our Sprout PIs, John and myself and Christina Olson, are the telehealth subcommittee for that grant project. So next slide. And this just is not a comprehensive listing, but gives an example of some of the collaborations that we've developed or the groups that we've worked with, looking at different organizations and societies. Obviously, the AAP is one of our sub-awardees, so we work very closely with them. We work with the HRSA Maternal and Child Health Bureau, the NCATS Clinical and Translational Science Award Consortium. So this is our grant funding is a CTSA Collaborative Innovation Award, and as such, the purpose really is to develop tools and resources and facilitate collaborations within the CTSA as well, and disseminate those to, and CTSA is focused on the conduct of translational research across the country. And so we disseminate those tools through the CTSA. We help build connections to folks with their CTSAs, and there's about 60 different CTSA hubs around the country. And we just try to streamline those approaches. We've worked with the Search Society, with the HRSA's National Consortium of Telehealth Resource Centers, with HIMSS and the Society of Academic and Emergency Management, Family Voices, and also currently working with the Delaware Clinical and Translational Research Institute on a project. We've provided letters of support for 11 grant funding applications. We have over 130 institutions that are part of SPROUT, but some of the collaborations that we've mentioned, working with Boston Children's Hospital for the integrated care program, and the others listed here. Also notably, we do have some international component working with institutions, especially in Canada, but also in Australia. And then we have a really strong component of patient and family representation. We work with Family Voices on developing some assessments for them. We're part of the Alliance for Patient Access, and they've stood up recently a telehealth focused group. And then there's a strong patient and family representation component in the AAP National Coordinating Center for Children and Youth with Epilepsy, which also has a strong telehealth component. So just running rapidly through all of that stuff, that's kind of an example of some of the collaborations that we've built, and we continue to build those collaborations with organizations and institutions, which has been really a rewarding experience for all of us, but it's nice to see all this stuff grow. And with that, I'm gonna turn it back over to John, or I guess I can introduce the question and answer part too. So we put some questions here as kind of to get people's thought processes started. We want to really engage the audience, and that means some of these questions we'd love to ask to the audience. So we don't want it to just be John and I back and forth. We want to give folks the opportunity to chime in on their own experiences or challenges with research, and make this real interactive back and forth. John and I can definitely chime in on a lot of these questions, and but we also really encourage folks to put their questions in the chat box. You can also unmute yourself and ask the question directly, and we strongly encourage folks to do that because it contributes to the interactive component. So I am gonna, while folks are thinking about questions or answers, I'll look at the chat box here. So one of the questions, how can we get involved in the TWIGs? So we have, you can reach out to Christina Coleman or myself or John about getting connected, and we can put our email addresses, and Christina is our amazing research coordinator for the overall project, and I can put her email address in the chat box as well, and Jesse Liffelman, also from the American Academy of Pediatrics, has been a huge support for us. And basically, if you're interested in a TWIG, we can get you signed up to participate. And I would also encourage folks that SPROUT operates through the American Academy of Pediatrics. The grant, the SPROUT-CTSA network, is kind of separate but related. We encourage folks to join the section on telehealth care for the AAP, which just allows you to be on the listservs and kind of streamlines our operations a little bit. If you are a pediatrician and are already a member of the AAP, then it's something like $35 a year. But you do have to be a member of the AAP first. If you're not a pediatrician, it's actually a little easier in some respects, because you don't have to be a member of the AAP. You can be an affiliate member of the section on telehealth care, and that just requires someone from the section to basically write a letter saying that you should be able to join the section on telehealth care. And that allows you to be a little bit more engaged with the overall SPROUT activities as well. So let's see, I'm checking to see if there's any other questions.
Dave, I put the Christina's email in the chat, and for those who I think Esther, you were asking about organization view of system. You can contact me, and I'm happy to talk through it with you, and anybody else who's interested in this organizational view. It's one of the things we're developing in Sprout to sort of kind of get a visual view of telehealth research. There's another one is the policy STEM framework publicly available, Dave?
Yeah, and I'd mentioned we're trying to get that published. If you have questions about that, you can reach out to me, or you can reach out to Brooke Yeager-McSwain, who is also working on that, and I can put her contact information on that in the chat as well.
It looks like from Megan and Cherie, interested in particular equity measures and indicators. There's actually, that's actually a great question. The equity twig is really kind of taking that on. And if you'd like to join it, please let Christina know, and we'll get you on it. I'm going to just kind of go to here we go. There you go. So this is a slide on the equity twig. It's led by Sansani Craig and Suzanne Park-Gorstein in Seattle. They have 3 task force, one for metrics, one for dashboard, and one for digital health equity interventions. So if you'd like to join, if you're interested in that, go ahead, go and join them. I can speak for the metrics metrics piece of this. There are 2 streams of work. The first stream of work is really to identify what the disparity identifiers are. And the reason, and that's important because a variable such as race, equity, such as, language preference, socioeconomic, determinants of health, those things, we tend to think of them as variables that can tease out potentially disparate groups. They're not quite, some of them are directly related to causing disparity, but many of them are not related to the cause and the process of disparity, but they do help us identify. So in the STEM framework, we incorporate that so that if we're measuring access to care, for example, we'll take a disparity identifier like social vulnerability index. That's an index that's put forth by the CDC, and there are many other ones. And we'll use that index to try to divide the cohort into those with high social vulnerability and those with low social vulnerability. We measure access in both groups, and we compare, and we see whether there's a disparity in access. So access in that regard is the outcome or the variable that is showing disparity, if there is indeed one. Whereas the social vulnerability index is a identifier of a disparate group. But that's the metrics group. There's great work going on about DASH. There's an effort there to collect the way disparity dashboards are being built around the nation by various institutions in order to visualize that data. And there's a group that's looking at directly, what the interventions could be. And one of the activities is actually, doing some interviews with disparate groups to try to get some qualitative information, and that's being done here at CHOP.
So there's another question from Helen, and I may say the last name wrong, Laboon, I don't know, or Laban. Asking about Laban. Oh, there we go. I got it on the second try. So indicators around quality and use of audio-only telemedicine. We don't want to use pandemic time data since it's too distorted, but it's also the only data we have. So that's a really excellent question and a very important topic because for a number of reasons. It plays directly into the equity and disparities question. And that's one of the things that's really coming out in the data that we're seeing is that disadvantaged groups, socioeconomically disadvantaged groups, minority groups are using audio only telehealth at a higher rate relative to video telehealth than other groups. And so think about the implications there, because if, say, reimbursement of audio only telehealth is cut, who are you disadvantaging, right? You're exacerbating the digital divide potentially, but we need to really look at that data to understand that better. That's why the research is so important, you know. And if you think about it, it makes sense, because the folks that you know, don't have a private office, you know, to go to, that work on a assembly line floor, or that, you know, have you know, live in a smaller apartment with 5 other people, etc. Where are they going to do a video consultation where there's any semblance of privacy? Where are they going to have the time to do that? It's not just about broadband, which has gotten a huge amount of attention as telehealth has expanded, and is certainly an issue. But even if you give everybody broadband, right, how do they actually use it in a way that will allow them to conduct a high quality telehealth visit when they got all these other, you know, there's all these other factors that play into that, you know. And broadband obviously is another thing that's playing into the higher use of audio only versus video, because even if someone has access to high-speed internet, if their data plan doesn't allow them, if their data plan is limited and they're going to take 50% of their data allotment for the month to do one telehealth visit via video, then they're going to use audio. So this is really important to understand, and it needs to be a huge focus, especially with the payment questions that are coming forth. And so, you know, the question is, how do we, you know, what data do we use, you know? And the pandemic data is skewed, but especially in the early phases, because people really shifted largely in many cases to audio only because they didn't have the video either processes or technology in place. But that doesn't mean we shouldn't use that. It means we have to acknowledge that as we're studying it, and help to and build our research questions off of that, right? Understand what was the, you know, how did the balance between audio only and video shift during the pandemic? And as you look at the data, think about how that data likely changed, or what other data we have to show, to demonstrate how that changed, and build that into your research, build that into your discussion. You know, if you're publishing a research article talking about audio only telehealth, you know, acknowledge that this, you know, during the early stages of the pandemic, this is what the situation was, and we have to take that into account when interpreting this data. You know, I think just being open about what you're seeing is important, because the other part of the question or comment that was mentioned, it's the only data we have. Yeah, exactly. But it's also a lot of data. Right? I mean, this was done so broadly across such a wide, every specialty, every hospital, every practice, everybody did it. This is a new, completely new frontier in the field of telehealth. We have an immense amount of data, and there is a lot of data on audio-only telehealth. And so we have to use that data. It is the data we have, but it's such a kind of treasure trove of data. And it's tied to reimbursement now. So you get payer data that you can tie into it. You can code geographic locations and things like that to really look at disparities, which is really what some of the work that we're doing with Delaware. So it's you know, like I say, it's really important, and we need to dive in on that, not just to help with, you know, the operational aspects of telehealth going forward, in terms of if you run a healthcare a telehealth program, how do you decide how you want to do audio only versus audio video? But it really gets to the heart of some of the key questions around payment, reimbursement, and the disparities work.
Yeah, I think that's exactly right, Dave. I would ask Helen. I mean, I think if you can unmute yourself, that would actually be great, because I do have a question about the distortion in what, and I look at the pandemic time data as, yes, it reflects pandemic time data, yes, and we sure couldn't, you can't extrapolate it to non-pandemic time data, but I think, as David saying, it's still quite useful. And I would maybe go back to, what question are we trying to ask around quality, right? And I bring back up this slide because depending on what kind of question or what that you're trying to ask, whether it's in terms of a comparison, audio versus non-audio for let's say high social vulnerability, highly vulnerable population versus not vulnerable population, you could still answer those questions. You could, with the caveat of asking during pandemic times, right? Which of these, equity groups, where the disparities are during pandemic time around, and I think, Dave, you and I have had experiences and have seen data that where the more vulnerable population tend to take advantage and use audio more, and right, and so
and
I
this
think
is actually, sorry. I was going to say, this is really where the STEM framework can come into play as well, because, what is your definition? Like you were saying, when you say indicators around quality, are you talking about clinical outcomes? Are you talking about process metrics? Are you talking about access to care? Are you talking about the costs and those sorts of things? Like how do you, the specific question is important, because use of audio only telehealth can have very different impacts. I mean, we all kind of assume, and then there's probably some data demonstrating this in various contexts. We assume that there's a decrement in clinical quality, outcomes, but then we actually need to see that play out, and that takes time, and maybe it's not as significant as we think. And I've heard a lot of folks talk about how they've been surprised at what they're able to accomplish just over the phone. So, and until we actually have some clear data to objectively show one way or the other, you can't even really say that the use of audio only telehealth clearly has a negative impact on clinical outcomes. But certainly when you look at access, we are seeing data that shows that access to care is improved through audio only telehealth. And certainly when you think about costs, you could easily envision how the cost of care could be lowered by audio only telehealth. So really, what are you targeting in terms of those outcomes? And using the STEM framework in our economic model that we're putting out, those can really help in directing those.
So, and you correctly intuited that my background is on reimbursement and the economics of telehealth, right? So that was what called the question of audio only. Part of the policy debate that we've been having, speaking of applying the research to policy, is whether clinicians are going to have a higher error rate using audio only than they would with audio visual. And the distortion that we saw in the pandemic time data was, clinicians were using audio only far more frequently than they normally would have because of the restrictions on coming in. And also they had been doing so without necessarily a lot of training or familiarity with the modality. So we could also suppose that over time, because of increased access to care, because telephone is often a better modality for like chronic condition management, for example, we would see in general a trend towards better clinical outcomes with audio only as a fully reimbursed option. But the specific concern was, are you simply making a lot more mistakes using that? And should patients in particular, in fact, today is the day this goes into effect in Vermont, should patients be warned that there's a higher chance of an error being made in diagnosis and treatment if they use audio only as a platform. So is that specific question that's really come up in the policy context here?
And that's a great way to really hone in on an important question. And I think it's also something that's studyable, you have to identify specific errors that you may be talking about, but it really allows you to target a research question or quality improvement question. And I think when you're talking about payment issues as well, the audio only, because it's so much more convenient, also from the payer perspective, increases the risk of overutilization, which is obviously a concern for payers. And we need to kind of take that question head on as well, because ignoring the question isn't going to eliminate the concern, and just saying no, it's not, is not going to eliminate the concern either. I mean, there's clearly a focus on that risk of overutilization with audio-only telehealth, and so how do we address that in a objective way using research and data, so that we can ensure audio only is leveraged appropriately, particularly for those that may not have access to or the ability to use a video conference, but also in a way that minimizes at least the risk of overutilization and potentially fraud and abuse from other actors in this scenario.
Yeah, I think that's a terrific comment, Helen. And Dr. Michelot actually recently wrote a comment on a publication. We had a STEM publication in pediatrics. It was a perspective paper, and Dr. Michelot called out to rigorously audit and assess telehealth programs specifically for safety. And I think in the discussion back and forth, we responded to that actually in pediatrics was that absolutely, the STEM's second domain about quality and cost, and within quality, we have safety. And one of the key things to I think recognize is that, telehealth is not the same as inpatient, right? We all recognize that. And, providers seeing patients remotely can't really touch the patient and perform some skill exam and maneuvers that we could do in person. So, these preconditions certainly raise the risk of diagnostic and other medical error types that can lead to patient harm. It raises it, we recognize that, but by recognizing it, we can actually try to mitigate those risks. I think, diagnostic errors and cognitive errors existed long before telehealth. It's always been there. And it's always been a subject and a target for safety, solutions, right? We now have telehealth as another aspect of that we have to consider. And I think using the STEM framework to really kind of call out safety, as I think you alluded to, is really important. The other aspect of this is I would, instead of comparing, telehealth versus like telephone versus telephone versus audiovisual comparison, let's go back to our Peacock research question. What about comparing to audio versus nothing at all? Right? I think that's a really important point that's often missed in these debates, is that, what is a comparison group? And oftentimes I think you're comparing to nothing at all, and maybe that's less safe. And so, so I think we have to kind of think of it in sort of those complex terms, various terms.
Yeah, and actually, just as you were saying that, Megan McGuire kind of asked the same sort of question, and I think that's an important distinction to make for a lot of folks, because when and historically, as you're building out telemedicine programs, often there's a erroneous comparison people are making in their minds to that you're really looking at telehealth versus ideal care in person. And in most cases, especially when you're really addressing access issues, that's not the comparison you need to be looking at. You should be looking at telehealth versus no access. And that, to take it to a little bit of the opposite end of the spectrum in terms of a telehealth program, the first telehealth program that I developed was pediatric critical care medicine outreach to rural emergency departments. And it was extraordinarily technologically advanced. We had high definition, pan, zoom, tilt, remotely controlled cameras that had a 12 times zoom. And, so I could literally zoom in and did on a lumbar puncture spinal needle and see the clarity or lack of clarity of the CSF as it came out of the patient's spinal canal from across the room, right? And so, and yet the question that people ask, especially when they were talking about, do we pay for this, is, well, it's not, it's risky to not have an intensivist present there and to be trying to do this remotely. And I said, yeah, it's okay. It probably is riskier than if I had been present at the bedside, but I'm never going to be. Like, there is no scenario where I can immediately show up at the Waccamaw Community Hospital emergency department when somebody calls with a critically ill child. And so it's the question, that the comparison is not how do I perform virtually versus how do I perform in person. The question is, how do I perform virtually versus how is the patient cared for in a rural emergency department with 50 other patients and practitioners who are not trained in pediatric critical care managing the patient, and me trying to help via phone. So it's really that comparison of telehealth versus audio only phone, with a provider who's trying to care for a patient at the same time that they're talking to you. So understanding that distinction is important. And I think, it's the same sort of question when you talk about audio only telehealth. Your comparison may be absence of care.
Helen, responding to the chat, I think the economist argument was because audio only has lower costs for the patient, no travel, no waiting, that may default to that convenience option over in-person, even when in-person is an option. Yeah, I think that's a great point, Helen, and I'd love to hear your thought about this as well, Dave. I mean, my initial reaction to that is, I think the clinician's response. I think the clinician has a professional responsibility to recommend in-person visit when it becomes difficult for them to assess the patient. I think we've been doing that as well, and so NICU program, for example, for follow-up, post-discharge follow-up, I have asked the patients to come to the hospital or to make an earlier clinic appointment because I was unable to reliably assess the patient, and I was worried about something, and that's okay. I think, and I think, to me, that's the other aspect, right? Of do we end up overutilizing, the emergency room or urgent care? I don't think so. I think we become a more judicious user of in-person appointments and in-person visits when we can do that. But I think it's left to the clinician.
And we've got a lot of questions coming in, which unfortunately I don't think we're going to have time to answer all of them. But the thing that I think I wanted to point out, because one of the comments was around, this is really a complex issue, and it impacts so many different areas. And there's certainly, people are bringing forth all very valid viewpoints, and a lot of this goes back to what's going to happen with payment and what's going to happen. How do you support programs? What should you be emphasizing? And those are the big questions. And I think when you're talking about that, anytime you feel like you're getting into the minutia of, right? It's not really minutia, but it's really getting into the complexity of a scenario and trying to figure out how to kind of legislate that. Or what should be the regulations, you really should consider the risk of over legislation or over regulation in that regard. And we may need to start thinking about having, really empowering our healthcare systems and our providers to do what they're trained to do and to make the appropriate decision at the appropriate time. And, obviously there's risks that come with that, and not everyone is going to practice the absolute best care every moment. But then how do you drive folks towards making those best decisions? And so should we be looking more at incentivizing high quality care rather than legislating to or putting in regulations to prevent lower quality care? And those are two different approaches. But if you're thinking about, how do you drive those approaches? Well, first, we have to identify what high quality care is, right? We need to answer those questions. That's where the research comes in. And if we can actually get the data to show, what is the best practice? What's the best approach? What is the ideal scenario? And then perhaps rather than saying, well, you can only practice this way because this is the best approach, and so we're going to put in regulations to prevent you from practicing in another way, maybe you should say, you know what? Here's the payment model that we're going to use to incentivize you to use these best practices. And we recognize that there are scenarios where that may not be possible. You use your clinical judgment in applying those, the tools that you have. But here's what we are, recommending and trying to incentivize towards. And I think that would be a much more, it's a streamlined approach, a lot easier to legislate and regulate, and would probably lead to the highest quality. But that's, my opinion. So.
Yeah.
Are we supposed to be done at 10:30?
Yeah, so we are actually supposed to be wrapping up. So I know there are so many great questions and lots of discussion going on, but we do have to close out. John and Dave, would it be okay if we shared, if you dropped your emails in the chat box?
Yes.
Okay, that would be wonderful.
I will do that with the warning that my email is insane and I don't always, it's hard for me to see everything sometimes. So if I don't respond to you, don't take it personally. It's probably because I missed it in the melee of my email inbox.
Jenna, if we can have a copy of this chat, or maybe we can, so I can send out a response. Dave and I can both send out a response just in an email to the group. To round things off. That would help as well. And
Okay.
We have monthly webinars on Sprout, so come join us and we can chat in that form too.
Wonderful. Yes, I will figure out, I believe our attendees were tracked here, so we will do our best and try and figure out how we can get you all a list. And I just want to say a big thank you to our presenters, Dave and John, for sharing your model and for all of your expertise and for a really great discussion. I know I was jotting down notes furiously and I learned a lot. So a big thank you to you both. We really appreciate it. And this session was recorded as well. So if anyone wants to go back and rewatch it, it should be recorded with the other sessions. And thank you all for attending this session. We will close out, and I believe the agenda will keep going for the sessions. But thank you again to John and Dave, and thank you to everyone who joined us today.
Thanks, Jenna.